At Haven, in addition to treating addiction, we treat mental health issues as well. In fact, we see mental health issues as critical to treating addiction. So we're going to address some mental health topics on a day-to-day basis. As part of our intake process and ongoing evaluation, we do assessments. And one of the conditions that frequently occurs, we call it comorbidly, or occurs with addictions, is bipolar disorder. In fact, our relapse prevention course, which was developed at Harvard, was developed for bipolar disorder and addiction. And their research shows that people who have had repeated treatment for addiction and continue to have problems, the number one condition that's being missed is bipolar disorder. And our experience has been that treating misdiagnosed or not diagnosed bipolar disorder can be a game changer in the life of someone who's struggled with addiction. And how we go about assessing for that is, first we do a structured psychiatric interview. We use the mini structured psychiatric interview, and that assesses for DSM criteria of several psychiatric disorders, including bipolar disorder. Looks for the signs and symptoms of depression, as well as for mania, which all the symptoms that are the opposite of depression occur in mania or hypomania. Instead of being down, the mood is up or irritable or grandiose, euphoric. Instead of no energy, there's high energy. Instead of being slowed down in the mind is racing. Instead of feeling an excessive guilt, there's no guilt. And people do self-destructive things, have no impulse control. They may engage in sexual activity without any guilt. They may spend money without any guilt. They may steal without any guilt. And they have big ideas. They think big. They plan to get rich. They think of how they can be famous. They may go without sleep for several days and not be tired, instead of sleeping all the time or not sleeping and being tired all the time. They have a heightened sex drive instead of no sex drive. Things like that. The other instruments we use are rating scales, psychiatric rating scales, in which they're checklists in which people endorse whether they do or not have certain symptoms, and these checklists or rating scales have been used in studies with people that do or do not have certain conditions, like bipolar disorder, and they have cutoffs on those. And if people check a certain number of symptoms and the points for those put them above a cutoff, the chances are more likely that they have that condition. For bipolar disorder, there's the mood disorder questionnaire, and there's the bipolar spectrum rating scale. A few conditions that often overlap with bipolar are ADHD, in that with ADHD you have problems concentrating or focusing, and that overlaps with bipolar disorder, because when people have racing thoughts in their mind as part of being manic or hypomanic, they can't focus or concentrate, or if they're depressed, they can't focus or concentrate. With ADHD, you have problems with impulse control, which occurs in mania or hypomania when people are high and have high energy and are acting without thinking, engaging in self-destructive behavior. And of course, with ADHD, with the hyperactivity, people have hyperactivity, which overlaps with the high energy state of bipolar disorder. And so sometimes these conditions overlap in symptoms and are difficult to tease apart diagnostically. You have to look at family history, you have to look at time course, you have to look at to what degree there are other symptoms that indicate the mood disorder rather than just ADHD. And there are times where people have both. and both have to be treated. Anxiety can overlap, and people with bipolar disorder often have a high degree of anxiety, especially when their moods are cycling. It makes them highly anxious. And so one of the problems that occurs is that when people are self-medicating, they often will self-medicate their depression and their low energy with stimulants. They'll self-medicate their anxiety with benzodiazepines, and they'll play their own doctor and decide that those are the medicines they need, that those are the conditions that they have. They have a condition in which they need a stimulant, they have a condition in which they need a benzodiazepine. It's possible they may, but it's also possible that what they need is good treatment for bipolar disorder, and with stability in their mood, they may not need a stimulant, they may not need a benzodiazepine, and they need to get properly treated and stop playing doctor in a lot of cases, and see how things play out with appropriate treatment, and think outside of their box, and think and put some trust in their clinician, and in some of the evaluations, the structured psychiatric interview and the rating scales. The clinical interview is the mainstay of diagnoses, and the rating scales and the structured interview are just tools to help in that. But it's the experience of the clinician and the clinical diagnosis from a direct interview that is the most